scientific publications in peer-reviewed journals. Currently, he is a research and publication advisor at St. Paul's Institute for Reproductive Health and Rights. I'm very much honored to call upon him today to come to the stage. So our moderators will introduce the presenters and we leave for 3 sessions, 2 at first, followed by discussion, and then we will have a third one, which will be held virtually. Thank you.
Thank you, Dr. Tasfai, for the generous introduction. So good afternoon, everyone, and welcome once again. Hope you had a pleasant time yesterday with the panel discussions and with the oral presentations. So now we will be continuing with the second session of the oral presentation. So I will proceed in announcing the first presenter and the presentation topic. So the first presenter is Mr. Jemaw Assefa. Mr. Jemaw has been working at Mary Stopes International Ethiopia for the last 10 years as contact center manager. He earned his BA degree in public health and in health education and promotion. He will be presenting on a timely topic and a real concern for countries like Ethiopia. As you may know, violence against women remains a major global public health concern and women's health threat during emergencies like COVID-19 pandemic. So in Ethiopia, there are also evidences from UN Women suggesting there is an increase in domestic violence cases since COVID-19 outbreak. So his presentation topic is on adapting existing safe spaces in response to increasing gender-based violence in the context of COVID-19 at Mary Stopes International Ethiopia. So I kindly call upon Mr. Jemaw to come to the podium to present what he has, and you have 15 minutes for presentation, so you may now continue.
Thank you very much for this chance. As Dr. said, my name is Jemaw. I'm from MSI Ethiopia. And let me tell you what I'm working in MSI. MSI Ethiopia has a variety of outlets in the compounds. And from that of outlets, SRH service, related service, we are providing such services. From that outlets, MESA Contact Center provides so many information and counseling service related with SRH issues. Changes. Sorry. Let me say how we are going to deal with JBV services in related to the MSI Contact Center service providers. MSI Center provides the contact center services, counseling and informations related with these topics. Our providers provide JBV services for those who are in need of our services, having a collaboration with UN Women's. These UN Women departments provide for so many supports for our contact center staffs, especially training-wise. We are getting this training related to JBV supporters and deal with support the information counseling supports for those who are in need of our services. So the next thing what I should have to tell you. Okay. Why we are providing these services for these groups, or what are the purpose of this presentation is to share you our experience, how we are going to deal the JBV support services. Our services providers following the training and platforms of the contact center, and we are supporting very much number of people suffering with gender-based violence problems. And we are adopting these conditions or these services, having, as I said in previous time, having such support from the UN groups, and so we are getting so many results related to our services. People are called to us following their exposure to violence, and we try to support them by referring to the delivery points. There are so many supporting delivery points for those who are victims of the JBV influenced problems. So what we get from this lesson, dealing with any epidemic circumstances, having such programs may result in what we call this a good success. Like we are preventing such spreading of problems, and we will try to support the mothers or the victims by referring these groups, and also to the concerned ones like legal concerned bodies and health facilities and other economical supporters. These all groups support the JBV victim groups, and that's why when we are exposing for the next time, if there's any type of pandemics, and having this alternative like contact center service may support or may provide sufficient support for these groups. So it is good for MSI as well as for the victims groups and also for Ethiopian mothers. This is what we faced, and if you need any clarity related with this issue, I'm ready to respond accordingly. Okay, this is what I have.
Okay, thank you, Mr. Jemaw, for your informative presentation. So because we're going to have enough time for discussion at the end of the second presentation, I will directly go to the second, to announcing the second presenter. So the second presentation will be made by Dr. Wondimu Gudu. Dr. Wondimu is working as a consultant obstetrician and gynecologist at St. Paul's. He earned specialty certificate in OB-GYN at Addis Ababa University Medical Faculty and master's degree in public health from Jijjiga University. He has been in public service for the past 12 years. Currently, he is the postgrad director of the OB-GYN department and final year fellow in maternal and fetal medicine at St. Paul's. He authored and co-authored in a number of publications in local and international journals. So his presentation topic is on managing resident workforce and residency training during COVID-19 pandemic, which is a scoping review of adaptive approach. So this topic, I can say, is relevant and interesting to most of us because as an academician, we know how this pandemic affected our day-to-day teaching learning activities. So we're glad to hear the adaptive approach and the different options. So I will kindly invite Dr. Wondimu to come here and present what he has. And you have exactly 15 minutes.
Okay, thank you very much. Again, thank you for the kind introduction. As you see, this is a topic of the scoping review. We said it's scoping. As you know, scoping is just to see the coverage of the literature related to something which is relatively new. So there is not such strong evidence on adaptive approach to training in the context of COVID-19, for that matter, other crisis situations. So these are the authors. These are the contents. So the introductory remark will be very much familiar to you. As you know, once it's declared as a pandemic, it has affected all healthcare provision and training. This is related with the COVID-19 infection itself and the adaptive mitigation measures which were taken. So the didactic, hands-on, surgical, as well as research were impacted definitely by the COVID-19. Additionally, rotation of residents in an institution and between institutions was also affected related with the pandemic. All these sudden changes will result definitely in significant reduction in exposure in all pillars of residence training, didactic, clinical teaching, hands-on training, especially in the surgical disciplines as expected. This eventually will have an impact on the residents' competency as well as accreditation process. So these unprecedented circumstances, they require flexibility and creativity with novel means of intervention to ensure the training is continued in the face of the pandemic. This needs to be done while maintaining the safety and the safety of residents, consultants, as well as patients. So having these underlying facts, we asked 3 questions for this scoping review. So what are available adaptive ways to continue the residency, clinical, didactic, and surgical training, as well as research? The second is what are effective means of maintaining residency safety during this pandemic, and what guidance are put forward in terms of accrediting residents in the training. So the search strategy, we identified websites involved in different residency programs. A search strategy was also employed, and different databases were searched using key words, which will be shown in the next slide here. These are the search query and the results in terms of retrieving the appropriate literature data. So the scoping review was definitely prepared using the PRISMA guideline for systematic reviews and scoping reviews. So the inclusion criteria, population, it will be residents, but irrespective of the training field. The concepts, the studies, reviews, statements, recommendations addressing residency training programs during the pandemic were included. So the context was worldwide. We didn't have any, limitation to a single area or country. So the type of documents retrieved were the already mentioned studies, reviews, editorials, perspectives, short or special communications, and position papers or residence education during the pandemic were considered. Sorry for the inconvenience. So the search was limited to last year because the pandemic just hasn't passed just a year. So data extraction was made by 2 independent, authors independently, and some disagreements were resolved by simple discussion. So these were the informations which were retrieved from the available documents. So the identified findings were thematically organized into 6 areas: staffing, safety, and clinical coverage for residents, clinical education, surgical education, didactic teaching, research activity, and accreditation process. So final narrative synthesis was done because of the nature of the review, which is scoping. So you see his intervention areas, the 6, and these are the authors. And also these were the findings, the findings of the different papers or documents that were retrieved from the scoping review. So when you come to the results and discussion, totally we identified around 404 records, which were hovering around the issues that were interested. After removing duplicates, we came up with 334 documents, and we retained about 34 for full text review. Finally, 13 were found to be relevant to the review. So this was the PRISMA flow. Sorry for the small font size, which might not be visible to some of you. So finally, you see that using different exclusion criteria and screening, we came up with around 13 papers. So the characters included the studies. Around 3 were articles, full articles. 5 were short or special communications, the rest were editorials and the perspectives. Actually, most of were the perspectives. 9 documents were reporting on resident staffing and safety. So 2 points came out from this area in terms of assuring resident safety, clinical service organization staffing. The first is dividing residents into groups and making them to serve, at clinical setup for 1 to 2 weeks and the other resting for the next 1 to 2 weeks. In some surgical fields, they divided into 3. Some of them might be engaged in research. One is clinical, the other will be having a rest period. Actually, not a active rest period. They will be engaged in virtual learning platforms. So this is more or less what I have said. These 2 statements goes on with the description. So related with the clinical education, meaning that morning sessions, rounds, case presentations, and seminars. Okay, related to that, few residence programs actually they totally suspended these training activities, but there were many adaptive approaches used by the different residency programs. So grand round webinars, live interactive virtual visiting professors, which was very important, especially for surgical fields, a virtual visiting professor, virtual academic conference, case-based conference, morning session webinars, which we are doing using different platforms and email-based clinical vignettes, and also sending clinical image to consultants and residents and having a discussion later. Virtual or live recorded conference were used in different residency programs. So as you see, this is, as I've already said in the introductory remarks, this just a scoping review. We try to see the coverage relating to the adaptive approach. So these are the areas. So it's not like a systematic review. It's not synthesized in that way. So in these different virtual teachings, employing various mechanisms such as using tools that promote interaction and audience participation were recommended. Okay, these different methods might be futile, unless there is good interaction between those who are providing the virtual, teaching means and those who are attending these sessions. Sorry, next. So the third area was related with resident surgical education, hands-on training. This is the area where there was only a very limited evidence or adaptive ways. There were only 3 means. One is 3D, video sessions, and live or recorded surgical videos, and also surgical atlas, especially in orthopedic and urologic residence training, they were used. The other, which is maybe a fertile one, is using simulations or simulator for hands-on training. Relation to the didactic teaching, there were a lot of actually many adaptive, effective ways of continuing the didactic teaching, meaning like seminars and lectures. So these were like virtual the virtual lecture, free virtual classrooms, teleconference, e-learning modules, and electronic textbooks. As to the research, it was affected, but somehow tried to manage it. Even they used, they exploited the opportunity of the COVID pandemic actually in devising new research projects between the residents and the consultants. So there was face-to-face as well as virtual mentoring of residents, as well as, as I said, starting new, actually publishable research. As to the accreditation, some have suspended totally the accreditation process for the obvious reason. But what's generally recommended is program directors, they should communicate with local accreditation bodies and local clinical competence committee to make sure residents meet the different accreditation requirements. In 1 or 2 residency programs, what they did is they gave additional didactic sessions to compensate for the missed clinical or surgical training. So just to come up with, the final 2-3 slides, limitation of the review, definitely it included symptoms mainly from surgical disciplines. And the other thing, most records were from a single country, US, maybe more than 2/3. And the included documents were not critically analyzed because of the nature of the review, which was scoping review. So what are the implications of this review for the practice? So residency programs must reorganize resident task force to ensure safety during the pandemic, and residents must be trained in infection prevention and the clinical setup, not only virtual, and appropriate use of PPE is recommended. There are evolving potential innovative approaches to sustain training in the different domains of residence teaching. And residency directors, they should devise mechanisms to ensure competency of graduating residents by working closely with accreditation bodies or local, different committees. So the implication for research is clear because this is a scoping review, then a larger and good research or with more evidence on innovative alternative teaching is recommended using different research methodologies. What about in the Ethiopian context? When you, after coming up with a scoping review, we try to see what will be the practical recommendation for the Ethiopian context. As you know, most of the residence teaching is very, straightforward, which was based on only face-to-face, okay, the conventional. In some residence training, there were different efforts to make, additional adaptive approach for continuing residence training in the normal circumstances. For example, the simulation, which has started in the different areas. So currently, what do we have? Maybe even now in the face of the pandemic and maybe in future, in conditions where we have a personal crisis or a crisis at the national level. So related with resident safety, hand in hand with ensuring adequate supply of PPE, dividing residents into at least 2 groups and arrange rotation for 15 days should be considered. So in relation to the didactics, they can be already started using Zoom, Microsoft Teams, or these didactics can be uploaded to a dedicated electronic platform, which was tried at the national level. Pre-recorded videos, e-learning modules, electronic textbooks can be other options. So as to the clinical teaching, exploiting Zoom and Microsoft Teams virtual platform for conducting morning session, case presentations, management sessions, seminar and lectures recommended. Case-based discussion, which can be made on social media or using individual emails and with further discussion can be one potential option. In relation to the surgical, we have only limited options. Maybe you can try live recorded videos and then simulations in an area where are good simulators, and using the 3D wave might be one good option. So in terms of research, especially in prospective type of research, is in-person or virtual mentoring can be done. And these were the reference used, and thank you very much.
Thank you, Dr. Wondimu, for the nice presentation. So now we will continue to the Q&A sessions, but I will invite the presenters to come to the front to entertain the raised questions. So I will give chances to the audience to ask or forward your comments or questions to the presenters. Dr. Taddasa.
Okay, thank you very much. So my question goes to Dr. Wondimu. Actually, it is a very nice review, but my main concern in the question is, have you tried to look the different setup, especially the papers where you reviewed most of them from US, and you know the actual practical difference between here and the US, especially residency program. Just to mention few of it, for example, in US, resident is actually a student, clear student. But here in Ethiopia, resident is not only student, resident is care provider actually. Maybe this is in one way it's important because as long as you provide care, okay, residents has to be available there. But in US, care providers are usually the staff of the hospital and residents are actually learners, okay? So considering these things, can you really conclude, recommend based on these factors? And the other recommendations, we know the difficulties that we have with the infrastructure, like the technologies, okay? The number of residents we have, the resident to faculty ratio, and the patients, okay, the volume of patients that we have. In one way, it could be positive because residents will have a good exposure to different cases. So have you looked into these things so that even the accreditation and things like that, residents can fulfill their logbooks without any problem, okay, and so on. So what is your comment on this issue? Thank you very much.
Thank you, Mr. President. Any other questions?
Okay, thank you very much. My question goes also to Dr. Wondimu. I want to applaud you, both of you, for a very nice comprehensive summary. I think both presentations were timely, and we have so many, we have learned so many experiences. So for Dr. Wondimu, I think together with the challenge, there are opportunities that the pandemic has brought. So in terms of residency program or in general academic institution, what particular opportunities have we identified? Probably that can be adapted and not only for the time of the pandemic, but that can be continued after passing through the pandemic. It can be in technological aspect or any opportunities that the pandemic has brought, which can be accustomed and can be continued even after the pandemic. And the other is probably similar with Dr. Taddese's question. The accreditation, as you have seen, as you have described, even in well-organized setup, there was some difficulty and irregularities. But our setup is quite different. Again, among residencies, there is some variety. Some of the residency programs, they really need quite so many clinical experiences to have an accreditation process. So what's your suggestion or what's your advice, especially in those residency programs, which really needs a skill like surgery and gynecology and obstetrics? How should be the accreditation process, and how do you recommend from your finding? Thank you.
Thank you. So maybe to add one question to Mr. Jemaw, how is COVID-19 exacerbating risks of violence for women in our context? So what do we have on the ground? We can anticipate like stress, disruption of social and physical contacts between families and decreased access to service. So, but what we really have on the ground, considering our context, and what can be done? What do you recommend for example, for different institutions, for Federal Ministry of Health or for other governmental institutions, for the communities and for international organizations and NGOs? And for Dr. Wondimu, it's clear that there is an obvious burden, but how do we balance this burden in the health system as well as the training or the residency programs? What do you recommend in that regard? So I will give the first chance to Dr. Wondimu and then to Mr. Jemaw.
So thank you for the questions. As to the first question, Dr. Taddasa, in relation to the context, this review was made, using the context and the world as a context, because we have specifically said in the inclusion criteria, the context will be worldwide. We didn't specifically review the adaptive approach related to some continental area or country to a limited country. That's one thing. And the recommendations are general, not context specific. Okay? So we asked ourselves which of these adaptive approach can be implemented in our setup, considering the obvious difference, as we said, in residence training. There is a huge difference the way residents are trained between the different setups, specifically in our country and the US. So that's why I have specifically included the last slide. Actually, that slide was not included in the original document, and this is actually a recently published paper in one of the international journals. So to make it more context specific, that's why we have added the last slide. So I have selected, maybe if the last slide is displayed, I could have elaborated on some of the points which can be actually implemented in our setup. Okay, most they might not be, considering the difference as to say the technological advance, whatever. But there are still viable options in all domains of residence training, including, for example, what we have started. For the didactic, simple virtual sessions, flipped classrooms can be good options, meaning that online we can email students or residents the seminar topics or highlights of a lecture. They can read on that. We give them reference books, they read, and then on one day we can do a virtual session where there will be a discussion on that topic. So flipped classroom actually can be even cascaded to the undergrad level. Using the Microsoft Teams, that's also one viable option. Related with the surgical, as I said, it's a very huge gap there. I don't know which method might compensate for the lost surgical skills training. The only thing that we might try will be live recorded videos, and in an area where there is a simulator, trying with a simulator. We don't have Atlas 3D websites and the so-called visiting professor sessions. In relation with the research, still that is a good, one of maybe the blessings of the pandemic, which was actually asked by the Dr. Tasfai. It gave us actually a good opportunity to work on research projects already existing and the new one. In relation to the accreditation process, maybe because it goes with what I am reflecting on. In the last slide, I said accreditation process, we put it as a question mark because there is no accreditation body in our residence training. That's a very big gap, and we forwarded that recommendation. There should be a proper accreditation body in Ethiopia. The accreditation is always left at the department level and maximum maybe at the institution level. But what are the minimum criteria, competence criteria to accredit a resident? We don't have still, very clear setup criteria. These are, something which is exposed by the COVID pandemic, okay? There was something going, we know that there is a problem in accreditation, but the fact that residents are not having good experience and surgical exposure exposed the lack of accreditation process in our setup. So this can be one thing that can be improved in the future. So the other question is what we can learn in post-pandemic. Actually, we came up some editorial based on this paper, which I can share you. We tried to forward that editorial short communication to one of the local journals, but they couldn't accept. We thought that was a good thing because COVID has exposed a lot of pitfalls in the conventional residence training. So we tried to identify in all the domains of the training what were the gaps and forward the opportunities, for change. So one is virtual learning. We shouldn't always rely on face-to-face classes. So we have already started virtual sessions that can be cascaded in the future in different conditions. So surgical training, especially related also the last question, more residents are coming and the number of patients in the residence might not be comparable so that residents will have adequate exposure. So in such cases, relying on other surgical means of training might be important, as already mentioned. We should prepare live videos, live recorded videos. We need to work on having a good simulators and preparing atlas, surgical atlas. These are good options. These were never taught. Maybe that's what sorry, these are the things that were exposed by the COVID pandemic. So maybe the last two questions I have addressed with what was asked with Dr. Kardassi.
Maybe regarding the infrastructures that we have at hand, do you want to comment on that?
Pardon, in terms of?
In terms of like the number of patients, the number of residents, and the infrastructures that we have. There was one question raised by Dr. Kardassi regarding that.
Yeah.
So,
okay. Thank you. One of the prevention method of this COVID-19 pandemic, stay at home. This is not that much experienced in our country. That's why people are liable to be exposed for these complications. In order to prevent such conditions, people or societies, NGOs and governments may practices how to handle such conditions. We have to practice in detail about it. And this is the our recommendations. If we are engaged with this problem, or if we are practice these stress management mechanisms, we will try to limit or we will try to reduce the chance of getting such complications.
maybe any additional questions?
For the next presentation. My question is, this is a scoping review. Is there any plan to do a proper systematic review? Because with the scoping review, the data that we have is going to be very, it's just a general review, trying to see what is out there, and it cannot give us any kind of proper conclusion. So do you actually plan to do a systematic review further? Proper review? And the other thing is, you've talked about surgical patients. Maybe I have missed it, when you when you selected the papers that you wanted to use for the scoping review, there were certain papers that were excluded. I wasn't exactly clear on how that was excluded, because maybe a cyber patient is something that is currently being promoted even for surgery, even though cyber patients are currently being tried in few disciplines in the residency program and also in the fellowship program. So is it possible that those papers that were not included have missed, because I haven't seen anything on that regard. It's not a simple simulator, but a cyber patient, it's actually a type of a simulator, but not what has been presented. So could those research have actually helped us review such kind of current technologies? And even if now it's a very short time since the pandemic has started, but it's not like we have a very limited data, because even if this is short, there are multiple papers that are coming out related with COVID, including in the residency program. So maybe if you can tell us how those papers were excluded. Thank you.
So I've tried to highlight in the introduction. This is a scoping review because of two factors. Because we don't have strong evidence. The other thing, the COVID pandemic has stayed just some months when we were doing the scoping review. That's why we specifically selected scoping review over systematic review. Definitely for such situations, the scoping review will be well suited compared to systematic review. But one thing that we should have considered, that I should have mentioned, is that this was done in April. So after April, there were a lot of papers coming out. So those were not included. Maybe if you include all those and having the previous 13 papers, we might come with a good systematic review. Since it's a little bit time intensive, we will try to go on with a systematic review. In relation to some of the missed articles, those articles which were removed were those which were not addressing any of the domains of the residence training, whether research, didactics, clinical, or surgical. Otherwise, any paper which includes even one domain of the residence training was included. But the search criteria and also the societal websites that we have tried to look into might have not been as such comprehensive enough, so that some of the papers might be missed. So I cannot guarantee that we have included all available papers even at that time.
Any other additional questions? We don't have. I think we have entertained all the provided questions. So for the sake of time, we'll be linking. I can thank you all the presenters for your nice presentation and discussion. And thank you all audiences for your active participation. So let us give them.
Good afternoon, everyone. Those of you who are here and also those of you who are joining us virtually, I would like to say welcome for the second part of the oral presentation that we are going to have. We were planning to have two presentations after this, but unfortunately we are not able to do one of the presentations due to the current situation in our country. So we will have one presentation that was recorded earlier. So it will be presented by Dr. Negalign Mechal. Dr. Negalign Mechal is an obstetrician and gynecologist. He is among the new graduates of St. Paul's Hospital Millennium Medical College. He is our own, recently graduated from the institute. So he's currently starting his practice as full-fledged obstetrician and gynecologist. Currently, he's working in Jijiga. So he will be presenting on an issue which is an important indicator in family planning service provision, which is assessing of unmet need in family planning service. So he will be presenting on the topic of unmet needs for contraception and associated factors among women having cardiovascular disease in St. Paul's Hospital Millennium Medical College. I would like to give the chance for Dr. Negalign to present from the record that we have. Thank you.
Welcome. My name is Negalign. The title is Unmet Need of Contraceptive and Associated Factor Among Women Having Cardiovascular Disease in St. Paul Hospital Medical Millennium College, Addis Ababa, Ethiopia. So, as introduction, cardiovascular disease complicate 1 to 4% of pregnancy. It is the leading cause of maternal mortality in the developed world. Prevention often concentrate on medical rifling and assessment and management of acute medical complications and appointment. Some providers also state contraceptive provision. The issue of contraception is given a little emphasis, so preconceptional care and counseling is very crucial. The rationale of the study: cardiovascular disease during pregnancy is challenging for care and treatment for the care provider. So the problem is so huge. And the emphasis is too small. And there are a lack of emphasis. So the objective of this is to determine the level of unmet need of contraception. And the basic objectives are to determine the level of unmet and to determine the factors affecting unmet need of contraception. So the methodology: institutional-based cross-sectional study was done from February to May 2020 among women with reproductive age from 15 to 49 years of age who have cardiovascular disease. And the study population is currently married or in union women with a reproductive age of 15 to 49 years with cardiovascular disease. Selection criteria were inclusion criteria was currently married or living in union, reproductive age women who had cardiovascular disease, and competent to give an informed consultation criteria were women who look acutely sick looking and unable to give uninformed consent. Women who come for the first time to the chronic clinic were excluded. The sample size was calculated based on the simple population formula. The value was taken as 50% because there was no similar study before. So 291 sample size was calculated and confidence sampling was applied to recruit the study subject. When you come to the variables, the outcome variable is unmet need of contraceptive, and independent variables were categorized into socio-demographic characteristics and cardiac care and treatment, and the reproductive and sexual characteristics. So the data collection and quality control, it was interview, administer questionnaire was used, and the unmet need part was taken from revised unmet need guideline 2012, and data was collected by 4 BSc nurses working in chronic medical clinic during working hour. Training was given to each data collector. Questionnaire was tested on 10% of the study participants before the start of data collection. Supervision of the research was continuously done by the primary researcher, and code was given on the back of the claims chart to avoid repetition. Data processing and analysis. Quantitative code was given to each case before the data entry. Data was entered, cleaned, and analyzed by SPSS version 20. S-square test by variate multi-variable regression was carried out, and p-value 0.05% was used to have statistically significant association. So this is a term that's used for operational definition. So unmet need for contraceptive was defined as a proportion of women who are not pregnant, not in postpartum amenorrhea, and are considered as affected and want to postpone their next birth for 2 or more years, or stop childbearing altogether, but they are not using contraceptive method. The second definition was women having mistimed or unwanted current pregnancy, and the third was postpartum amenorrhea, and their last birth is within 2 years, and it was mistimed or unwanted, and the other terms are here included in the operational definition. When you come to the ethical consideration, the proposal was approved. Approved by the IRB of SINFO with this reference, and informed consent was taken from the participant. Privacy and confidentiality of the participant was assured, and the right to withdrawal from the study was given to the participant. So the resultant discussion, 291 women were included. Among these 7 were non-respondent, and the total response rate was 97.6%. So 284 women provided a complete information. So the socio-demographic characteristics, the age range from 15 to 49 years age were participated with a median age of 34, with plus or minus 7.4 standard deviation. More than 80% of the participants had attended formal education. 7.5% were housewife, followed by a merchant. 60.2% of women have no their own income. Among women having monthly income, the income range from 500 to 10,000 Ethiopian birr, with the median income being 3,300 Ethiopian birr. The sexual and reproductive characteristics, 70.1% used modern contraceptive at least once in their life, and during data collection, only 30.2% were using contraception. There were 51 pregnant women during the study period. 63.4% of the women have a partner support to use the contraception. More than 87% of the participants were sexually active within the past 1 year. When we see the cardiovascular care and follow-up, and more frequent type of disease that we observed were hypertension, followed by chronic valvular heart disease, and the congenital heart disease. More than 80% of the women has follow-up at least 1 year and above. Preconceptional counseling and care, despite having multiple visits in the cardiac clinic, majority of the women lack counseling. So 62.7% are not counseled for unintended pregnancy. 61.3% were not counseled for future pregnancy plan. 56% were not counseled for contraceptive use, and 70% were never sent to family planning clinic for counseling and contraceptive provision. The total unmet need of contraception was 36%, 26.8% for spacing, and 9.2% for limiting. This is much higher than the national figure, that is 22% in the national figure, and 11% for Addis Ababa population. So total unmet is 36%, so it is higher than the national figures that we have in EHS 2016. And the contraceptive prevalence rate is 30.2%. Also, it is lower than the national figure. The demand of contraceptive is 66.2%. This is also higher than the national figure, that is 58%, and the demand satisfied is 45%. It is lower than the national figures we have in the EHS 2016. So the reason for not using contraceptive the most common reason that the patient responded with side effect, fear of drug side effect and drug interaction, followed by the low perception to pregnancy. When we come to the associated factor, age, educational status, income, occupation, and ever gave birth has no association with the unmet need of contraception. So previous contraceptive use, marital status, and contraceptive counseling had an association. Also, partner support on contraceptive use had an association in this study. So unmet need of contraceptive was found to be more likely among women never used contraceptive method before and never counseled on contraception support on contraceptive use, as you see on the adjusted ratio of 3.2, 6.7, and 6.2 with 95% confidence interval. And the unmet need of contraceptive was found to be less likely among women having collaborative decision on contraception use with their partner. And frequent counseling also shows less likely having unmet need of contraceptive with adjusted odd ratio of 0.09. So the strength of the study, this study is the first study in this setting addressing women with cardiovascular disease and contraception. This study defines unmet need of contraceptive according to DHS 2012 analytical study, which is most recent and updated algorithm. Logistic regression was used to control the confounding factors and associated factor with even a special focus. So the limitation of this study, the exact reason for unmet need of contraception was difficult to know because of the nature of study. It was cross-sectional study. And sexually active women currently unmarried were not included. This may undermine the level of unmet need of contraception. Why it was not included is because the questionnaire for unmet need of contraception is slightly different than that of the married one. So data was collected only in one institution. This study didn't examine the provider factor, knowledge, attitude, and practice. So in conclusion, so the level of unmet need of contraception is high. When we say high, it's higher than that of the national figure. The contraceptive prevalence ratio is unacceptably low. There is a gap in counseling for contraception use. Fear for drug side effect and interaction, perception to low risk for pregnancy were common reason for not using contraception. Marital status, previous use of contraception, preconceptional counseling, and partner support were associated factor. So my recommendations are contraceptive counseling should be strengthened in chronic clinic, and partner involvement should be encouraged, and further studies needed to provide factors like knowledge, attitude, and practice. And finally, I want to acknowledge the college, the Department of Obstetrics and Gynecology, cardiac clinic staff, and all data collectors, and my mentors. These are my references. Thank you.
Yes. Okay. So as you have followed, he has presented his research, as I said, on a very important indicator in the family planning service provision. Now this is the time for question and answer. So I would like to receive questions from the audience here and also those who are following us online.
Thank you, Dr. Negalign, for the nice presentation and an interesting topic. This kind of research should be extended to other chronic medical illness and psychiatric patients and also other oncology patients too. My question is, have you tried to look about the duration of their diagnosis? Because the duration of their disease, or how long have they been following in St. Paul chronic medical illness like outpatient clinic? Because the time will affect their knowledge. The number of visits also depends on the duration of their diagnosis. So have you tried to see that with the associated factors? The other is, if I miss it, I don't know, but have you included those who are pregnant because of they are not using contraceptive, like those who have unintended pregnancy in your research too? Thank you very much.
So, any other questions?
So I also thank the presenter for the nice presentation. Would you explain us from which departments you have tracked the clients, because this cardiac patients might happen into different departments. So from where OPDs, or from which departments exactly these CVD patients were tracked? And is there any reason that hinders the researcher to go beyond sample? Thank you.
Any other question?
Thank you for the nice presentation. My question is regarding with the method of sampling, because a specific number of the participants is known. Why did you specifically choose convenient sampling? If you have a sampling frame, why not a systematic random sampling?
Any question from electoral audience? So, in the interest of time, shall we entertain those questions if Dr. Negalign is already?
Okay, thank you. I can hear you. Can you hear me?
Or do you need a summary, or you can entertain those you have already heard? So if they are missing, I'll just jump in. Okay.
Okay. I will start from the first question, the duration of the disease. It was collected from the data, the minimum amount of the minimum period of the duration of follow-up was 3 months, and the maximum was 20 years. And from the chart from the slide that I presented, can you hear me?
Yes.
Hello.
Yes.
So from the chart, at least 80% of the clients had follow-up at least 1 year, but the minimum was 3 months, and the maximum was 20 years in duration. And the second question was pregnant were included or excluded? It was included from the collection. There was 51 pregnant lady during the data collection period, but for the calculation of unmet need of contraceptive, the pregnant the calculation was made based on the pregnancy, the current pregnancy is wanted or unwanted. So pregnant ladies were included. And the third question was, where do you collected the data? It was the data was collected in St. Paul Hospital Medical Millennium College in medical clinic. There is a cardiac clinic there, and it is on Tuesday and Thursday. And so the data was collected in the cardiac clinic. And the third question is why only one institution? Because the time constraint and it was the time constraint. As you know, the time given for residency, we are so busy, and I collected only in St. Paul. And my initially during proposal, I was during proposal, the suggestion was also to collect in the same institution, because it may be challenging to collect or to include other institutions. And the method of sampling, I used a convenient sampling because it was difficult initially. Initially I tried to find the whole appointment of the cardiac patient, but it was difficult. There is no, it was not straightforward in the appointment logbook, and it was difficult to find the patient. So I used the convenient sampling until the sample size is fulfilled. Thank you.
Probably we can take a few questions if there are any missing question that you would like to ask the presenter. We can still entertain one or two questions. So we have questions online? No? So if not, I would like to again thank the presenter for a very nice topic on a special population group. So as it has been already mentioned by the audience, one of the participant, that this kind of issues has to be also entertained in other patients with other chronic conditions. So this is a very important topic in that regard. This is our first presentation, and thank you all for your active participation. Saying this, I would like, as I said earlier, would like to acknowledge our other presenter who is not here, who is not able to present his research because of the current situation in the country. So we need to acknowledge his participation. His name is Dagana Bahare from Aksum University. So because of, as I said, the situation, he was not able to give us his presentation in due time. So it's very important that we acknowledge his participation, his willingness to participate in this important event. So thank you so much. And with this, we end the second part. Thank you.
Thank you very much, the moderators, as well as the participants for the very warm participatory discussion. So our next session will be a break. We will have a 10-15 minutes break, and then we'll be back for to attend state-of-art lecture by world-class experts. So now we can go for tea. Thank you. Thank you very much again. I hope you had a nice 15 minutes break. So our next session will be a state-of-art lecture. So I will call upon Dr. Stawa to introduce our state-of-art lecturers. Dr. Stawa is a very close colleague. She's an obstetrician and gynecologist and family planning fellow. She's currently working as a medical officer at the World Health Organization. Please, Dr. Stawa.
Thank you very much, Dr. Assefa. Okay, so we are now proceeding to the next two sessions, which are going to be the state-of-the-art lecture. This is going to be a very critical thing that every one of us would really enjoy, I'm sure. And the first presenter who's going to give us the first state-of-the-art lecture is going to be Dr. Dorine Irakunda. Dr. Dorine Irakunda is a clinical advisor at PSI, where she works with the country team to improve the overall clinical quality of care of sexual and reproductive health services. Dr. Irakunda provides technical assistance to build the capacity among PSI in-country staff to enhance self-centered care and sustainability of their quality of care systems. And she has been hugely involved in the development of self-care framework, and it's piloting in different few countries. And previously, Dr. Irakunda was the SRH Department Director at PSI Burundi, where she oversees evidence-based practices and service implementation and provisions. And before she joined PSI, she was supporting local NGOs in Burundi called Mission Shalom, and to improve the prevention of treatment of common childhood illnesses, birth preparedness, maternity services, and also management of obstetric complications. Dr. Irakunda receives her MD from the University of Constance in Algeria. So Dr. Irakunda is going to present to us on self-care and self-management, specifically self-care at the era of COVID-19, which is one of the innovations currently, where we are trying to bring more practices to the self-care and bringing more practices to the women and those who are really needing reproductive health services to their hand. And it increases more promotion and also preventions and different services in reproductive health. So we will directly go to her presentation. So we'll leave the stage to Dr. Dorine now.
To this second National Summit on Reproductive Health. And thank you for the invitation. It's a great opportunity to talk about self-care, especially during this COVID-19 pandemic, and to look together on how it helped to ensure continued availability and access to SRH health services. So this is the presentation overview. I thought it might be useful to start with some background and look together at what self-care is, its benefits from the individual and health system level, and especially how self-care helped with continued availability of SRH services during COVID-19 pandemic. Then we'll look at some practical examples at those three levels. We'll look at practical examples from the individual lens, health system lens, and then the self-care efforts that are out there to ensure the link between the two. And I will share some concluding thoughts. So, what's self-care? We all know that self-care existed since the beginning of time, and yet it's now receiving more attention for its capacity to strengthen health systems and contribute toward universal health coverage, particularly during this COVID-19 pandemic. So as defined by the WHO, self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability without the support of a healthcare provider. Seen like this, we all understand that in one way or another, we've been part of self-care interventions, either to treat ourselves or to treat our families. So as we see on the diagram here on the bottom right, self-care spans for self-management, self-testing, and self-awareness with different examples on each step. We can also look at self-care from its 4 dimensions, thinking about drugs, devices, diagnostics, and digital health. So this is the WHO conceptual framework for self-care. Here, I want to share some benefits of self-care to individuals and health systems. When you look at this from the perspective of an individual and from the perspective of health system, we can see that we have a lot of insight. The WHO identified the key principles, places of access, enabling environment, and accountability. But we can also talk about the benefits of self-care to individuals from the individual perspective. We know that self-care helps by providing a greater autonomy and agency over one's own health and increase access, particularly for stigmatized services and all populations. Here we can talk about the HIV self-testing, which is really a great example to reach people at high risk of for HIV who may not otherwise search for testing services, such as sex workers or men. We can also think about contraceptives, awareness and use among youth through self-care approaches, which is also a great example of where self-care can play a major role to ensure continued availability of SRA services. Now, at the health system level, which is all around the individual here on the framework, self-care helps to get health systems that are more equitable and efficient. By efficiency, this doesn't just mean cost savings for MOH or at the individual for the individuals. It also means that health providers are not overstretched and are really making the most of their time and skills. So I should add that encouraging self-care among physicians themselves is also an important piece for a strong health system. And on the interaction between the two, right, because we want those two aspects to speak together, self-care allows individuals to exercise a greater autonomy and control in meeting their needs, their health needs, but at the same time, MOH and health programs must adapt to recognize an individual engagement in their own care, and they must adapt through the quality of care systems. We are going to look together at some examples on how some countries are doing that. Now, let's look at benefits of self-care during this COVID-19 pandemic. This is the updated version of the operational guidance for the WHO operational guidance for COVID-19 context, which really mentions self-care as a great opportunity to strengthen and support health systems. So self-care offers continuity of services in a low physical touch environment. Let's just think about, for example, customized e-counseling. Secondly, it will help reaching new users in a safe and effective ways. It reduces the strain on overburdened health systems. So key recommendation from this guidance is really to think about digital platforms but also to think about redesigning chronic diseases management strategies around limited or adapted provider encounters, and to ensure availability of some SRH products without prescription, like OCPs, ECPs, HIV self-testing, HPV DNA self-sampling, and DMPAC self-injection. So now that I provided some theoretical background on what self-care is, let's look together at some practical examples. As I stated earlier, I will be sharing PSI and partners interventions from different countries, and these have been regrouped in 3 categories. We will have self-care efforts looking at individual lens, at health system lens, and on the link between the two. So here is, this slide shows 2 examples. On the individual lens, I will talk about products or devices and digital health solutions. So there is various SRH self-care interventions and SRH products, and I think WHO identified some in the guidance that I was talking about. But I thought about sharing this Kaya diaphragm because I think it's less known globally, but it has been there for long now. So the Kaya diaphragm is a newly designed version of diaphragm. It's a device, not a product. And with the support of USAID, it was developed by PATH and partners through an interactive human-centered design process, which led to several design features that make Kaya easy to use, especially for new users, and comfortable for post partners. So it's a non-hormonal method, it's discreet, it is woman-initiated, and reusable for 2 years. And it's a single size. This was not the case for other diaphragm, which needed a provider support to before use. But this one is a single size, eliminating the need of a provider fitting before use. So this introduction was done under the ECO project, using 5 stages, some of which occur concurrently. Those 5 stages are, the first one is regulatory assessment and product registration. The second is consumer and market research. The third is procurement and quality assurance. The fourth, marketing, distribution, and service delivery. And the last one is the monitoring and learning. Those stages, some of those stages can occur concurrently. And as you can see, all those stages require close collaboration at all levels, from the Ministry of Health to the community. So I also thought about talking about the great experience in Ethiopia with HIV self-testing intervention. This was piloted in Ethiopia by PSA led the pilot, but it was in collaboration with USAID, Ethiopia MOH, and Ethiopian Public Health Institute. And the main target for this was female sex workers, adolescent girls and young women, and high-risk men. This year, COVID-19 significantly interrupted facility-based and community outreach HIV testing, and the MOH agreed or provided its approved this year the unassisted HIV self-testing approach. So here with the unassisted HIV self-testing approach, clients report positive screening results by phone and are linked with confirmatory testing and follow-up. So now let's look at some examples of self-care interventions at individual end, but around the digital health. I will share digital health solutions looking at client journey from awareness to decision to service uptake to continuation of services. Let's first start with awareness and decision. So let's talk about virtual counseling, which can provide personalized information through SMS, short messaging, or through Facebook or WhatsApp using a chatbot. This has been done in a lot of countries, like Côte d'Ivoire, using a Facebook page called Entre Nous, and Nigeria and Kenya, to name a few. So these platforms provide a safe space for counseling on contraception, including SRH topics like menstruation, fertility awareness, etc. Some topics that are really appealing for young people. And they have also integrated COVID-19 prevention messaging. So this includes a referral system to the nearest health facilities, pharmacies, or a link to a community health worker. And when we are looking at service uptake, PSI Uganda partnered with an online distribution site called Jumia platform, which provides secure information, refer clients to registered health facilities and pharmacies identified by PSI and partners. There is also what they call safe borders for sales, for distribution of contraceptives in pharmacies and clinics. PACE Kenya as well, through the DC project, ensured a door-to-door service delivery of contraceptives and PPE, targeting women with disabilities and rural women. So those are few examples of what has been done for self-care interventions at the individual lens, using a digital health solution. On continuation, we know that discontinuation or irregular health uptake is a major barrier to improving health outcomes. So PSI is really engaged to gather insight of client experience to continuously improve its services. So with COVID-19, fieldwork was interrupted. And for example, under the DISC project in Uganda, they conducted a remote consumer insight using through phone interviews for a continued quality improvement of the self-injected DMPST service provision. So with everything, there is always challenges. So the main challenge with digital health solutions is that it leaves behind a portion of population who do not have access on these devices, such as phones and computers. And we also have internet challenges, but the main one is the portion of population which stayed behind. But here, the key information to keep in mind is that this mechanism of engagement do not replace the health worker-led engagement model. Rather, these new digital engagement options or self-care approaches complement and are in addition to existing health worker engagement. This pyramid at the bottom right shows that perfectly, showing that we have self-care at the bottom of the pyramid, followed by community care, followed by pharmacy-based services, and followed by primary care and community services, and then we will have district hospitals and specialist services. So now let's look at the health system level, what's happening there. So at health system level, several countries, including Ethiopia, Uganda, and Nigeria, are developing or starting to think about developing consolidated guidelines for self-care as a key step toward approaching self-care in a more coordinated way to strengthen health systems. In this slide, we talk about in Uganda and Nigeria under the DISC project, the DISC, which it's the delivering innovation in self-care, funded by CIF. So this year, both countries have established the first of its kind technical working groups that look at self-care across multiple health areas rather than siloed interventions. Both countries are well on their way toward developing self-care guidelines, which are encoded into the WHO consolidated guidelines for self-care, and are applying new frameworks that are available, such as the digital health framework and the quality of care framework that we talk later, right after this slide, on which I will talk right after this slide. And the key challenges, as mentioned here, is agreeing on the scope of self-care intervention. Both countries have agreed to start with SRHR services mirroring the WHO guidelines, with the intention to add more health areas down in future versions. As next steps, the guidelines are now a key milestone by itself. So as next steps, we'll have costed implementation plans and subnational planning. We have policy or regulatory change on specific products and or channels. And we also work on grassroots advocacy to institutionalize change into practice. Now let's look at the dynamic between the two. So through self-care interventions, clients may be interacting really minimally with providers or not at all. So we need to find a way that health system can monitor and support the care a client is accessing on their own, while also ensuring that its approach does not inadvertently hinder a person's ability. So PSI and its partners under the Self-Care Trailblazer Working Group, which has more than 50 organizations, developed and shared a new quality of care framework for self-care that aligns with framework and definition of self-care put forth by the WHO. The main goal of this framework is to really help, to effectively help health systems to monitor and support clients accessing health on their own. Its aim is to help programs, implementers, ministries, and health workers to understand how quality may be monitored and evaluated for self-care. The framework has around 41 standards, many of which assess from the client perspective versus the provider perspective. So now, after looking at all of these, what could this mean for us, for you and me? So I think and hope that this presentation will help mitigate opposition to self-care. And I invite people to get to know existing and helpful tools already available in the sphere of self-care and learn from each other. So the new quality of care framework and the framework for digital health are two examples of frameworks that support the shift from interaction with specific approaches to self-care to a systems-based approach for self-care. But they are they will be useful if people start to use them and share the experience in forums like this, and that will be also an opportunity to improve them. So you are also welcome to join self-care coalitions and community of practice, like the WHO Community of Practice, the Global Self-Care Federation, or the Self-Care Trailblazer Group. All those are community of practice that are already out there. And finally, of course, invest in self-care. We've seen, for example, for PSI only during this year, with COVID-19 pandemic acting as an accelerator, we've seen around 318 adaptations to COVID-19, among which 168 was for SRHR. By adaptation, we mean that any modification made to a plan, program's activity, intervention, or approach due to COVID-19. And most of those adaptations were around digital demand creation, but not only for family planning, but also these digital solutions were integrating COVID-19 prevention messaging, as well as e-counseling. And one of the lessons learned was the immense client interest in digital demand tools and the fact that this was an opportunity to expand FP self-care. So knowing that we do not have all answers yet to self-care interventions and that self-care in healthcare is going to be a long journey, I think we should start organizing ourselves while leaving plenty of room also for innovation. So there is still much to learn, and you are all welcome to learn with us. Thank you for your time and attention. I hope you have learned something from this presentation, and I welcome any questions. Thank you.
Okay. On sexual and reproductive.
Directly first go to some questions and then some comments that anyone could have. So we will be taking first from the stage and then from those who are online. So, okay.
So, thank you for the presentation and highlighting a relatively new way of providing care in such a tempting time in developing countries. So my first question is, what were the evidence, okay, to recommend self-care, especially in resource-constrained settings? Because already the challenges are reflected in the presentation. There are also additional challenges which might be country-specific, including having smartphones, good internet connection, and also the availability of telehealth at national level, the interaction between community-based providers, and also the patients or those who are having self-care there, okay? The medical technology, all these are the challenges. So what were the evidence to recommend self-care at this time? Do you have strong evidence? The other thing is the role of community-based health of workers. Is it considered what will be the role of the community-based health care providers in self-care? It's not well elaborated. And I didn't understand one concept, which is adapted provider service. What does it mean? If it is elaborated, it will be good. These are the points, but it would have been nice if somebody from the Ministry of Health could have attended this presentation, because we have heard yesterday that, okay, so maybe they can reflect on some of the points, especially context-specific challenges that we might have in implementing the self-care strategy. Thank you.
Thank you. Very good thoughts and questions forwarded. Okay, we will take two more.
Okay. Okay. Thank you very much for your nice presentation, the different dynamic, the dimension of care. So maybe my question and the comment is almost similar to this, Dr. Wondimu, but to elaborate more, in countries like ours, especially where illiteracy rate is very high, the population awareness about disease, about complications, okay, the knowledge level. So how do you see these things? Because I can just bring, a practical example where I faced before. Okay, I think before some years, Ministry of Health approved the PPH prophylaxis for active third stage management with misoprostol, like 600 microgram PO, and that was distributed for the community through extension health workers. So we're seeing complications related with abortion, people taking misoprostol for second trimester pregnancy, and then the fetus expelled, the placenta remain, and I have an experience of several patients who had really present with shock. So this is mainly related to the awareness. You know, when you give certain medications or certain care, medication for some condition, people tend to take also for others without knowing the consequence of that. So how do you see these things? Thank you very much.
Okay, thank you very much again. Thank you, Dr. Irakunda, for bringing such an enlightening talk and very timely one. My first question will be, how is the legal aspect of self-care? So whenever we think about self-care, the legal aspect and the policy of the country comes into play. So was there any policy dialogue? I mean, there were such an inspiring experiences from these countries, and I would really like to applaud those rich experts and rich providers who have been, fighting through this pandemic to make sure that the RH services are being provided. But how was the legal aspect in those countries have been addressed? And the other thing is, the question goes in line with Dr. Tadesa's question, the issue of quality assurance. How was it addressed? What were the things that have been done to make sure that these self-care recommendations are evidence-based? Thank you.
Okay, thank you both, and thank you all. So we will now proceed to Dr. Dorine for Dr. Dorine for the responses. Then, if there are other things, we will get back again.
Thank you, everyone. Good afternoon. I hope you can hear me. Thanks for these great questions and excellent questions. I think I don't have all the answers, but I'm going to try to tackle some of them, starting with the first one on the evidence to recommend self-care. The first thing I want to share is that to consider self-care as a way to extend care. It's not on its own sufficient, but it can be there to respond to a certain demand. And to mention also that self-care evolve according to the health system preferences. Or can you hear me? I hope you can hear me. Good afternoon. Hello, can you hear me? Okay, great, thank you. Okay, so I was saying that self-care adaptations must respond and evolve according to health system preference. So here, what I want to say is when we think about self-care, it's really a big or a broad sphere. But when we look at it in terms of products, devices, digital or other thing, you can see that you can do a lot in that area. The first question was more focused on digital health solutions and how to work with the community health workers and challenges around internet and etc.
So the first thing with self-care interventions, this is something you need to develop and put in place with the community in which you are going to operate. We like to include communities during co-creation sessions and really to look at what may respond to their need, which means in an area where we don't have, there is no internet or there is a really less penetration of phones, we are not to come with digital solutions, but more we can come with other products like Kaya Diaphragm, for example. In Niger, the example I shared, it was Kaya Diaphragm, which has been used, and to ensure continuity of care, community health workers were playing a major role in that introduction. So with looking at, I'm going to also to think about the second question, where the party, they talked about countries' illiteracy and knowledge level. This is to mention, for example, the quality of care and the 5 domains we like to look at, which are technical competency. When we are thinking about technical competency, we need to make sure that beneficiaries in that area are going to be able to self-manage their care, to self-refer if they need further services, and they must know where to go. So if, for example, in environment, the illiteracy is really low, this is where we work specifically on communication materials that must help them to accomplish what we are talking about. We will less rely on digital health solutions and we more rely on images and tools that can really help them to do what you are expecting from them. And the continuity of care, which is also part of the 5 domains of quality of care, is a really big component of self-care, where we want people to continue having access to needed care. So I think here I'm answering to those 2 questions together. And then the third one on legal aspects, what I want to share here is everything must be done with the MOH application, which means that we need to look at, if you are introducing a new product, for example, we need to look at all the components of it, from the registration of the product, from where it's going to be distributed, how client or beneficiaries are going to be able to use it, how many products you are going to be able to give them, follow-up care, etc. So this is why the Ministry of Health is really important to be part of the whole process. And it's, for example, in Nepal, as an example, Nepal is allowing for access to misoprostol without providers, for example, for self-managed post-abortion care. So this was a policy or a regulation change in response to COVID. Before it was not like that, but in response to COVID, they were able to allow access to misoprostol. So other places we can talk about the OCPs, oral contraceptive pills that are being available without prescription. So these are a few examples around legal aspects, but as I stated, this is some discussions that needs to happen with the Ministry of Health. Thank you.
sense of self-care. As it has been presented by Dr. Dorine, you have seen that there are different components of self-care. And one of the things that usually comes to a challenge is when we are talking about the self-management aspect of self-care, which Dr. Dates has also raised as a challenge when it comes to like knowledge in regards to some of the medications that we want to use. So this will be something that we can think of. And the other thing is there are always challenges whenever we are bringing new change, but self-care, especially the self-taste component, the taste component of self-care has been in practice for a longer time. And it depends on which country or which experience we're talking about. For example, from Nepal, as she said, there are now evidences that are even coming with post-abortion complication management with use of misoprostol. And there are even now discussions whether either we have to consider self-care practices, like the wider sense of self-care practices, especially self-management, and like earlier abortions, or the one that has been with the ministry now is with more of the family planning related self-care, the DMPA subclinics. So we have now online Dr. Mulat from the Ministry of Health, and if there is anything that Dr. Mulat you want to respond, I will give you the stage until we have Dr. Dorine back. Okay, Dr. Dorine, you want to get in? The questions are, do we have, okay. One is regarding.
Can you repeat questions? I think I've missed them. Can you repeat questions? I think I missed them.
One is regarding evidences that you can share with us rather than just country experiences. The other one is what do we have on adopted provider services? What do we mean? Can you elaborate just shortly for everyone? Over to you.
Thank you. So, for example, on adapted provider services, here what I meant was more on with COVID-19 pandemic, for example, we know that providers were really overloaded by the demand and you know, beneficiaries asking for services. And one of the way countries try to adapt this was, for example, with family planning services, to develop the electronic counseling. We all know that counseling take more than 20 minutes to providers before offering services. And this was really helpful because in some settings, as I stated before, this is possible. So they were able to develop electronic virtual counseling where a client can discuss with a virtual companion and ask questions. And the way the virtual companion was centered, it was asking clients questions that will help the tool to understand clients' need and then suggest the service, the family planning product that may be tailored to the client's need, and then refer the client to the host facility, linking beneficiaries with providers in an easy way. So this was helpful because in that area, here I'm talking about a pilot that happened in Côte d'Ivoire. In that area, clients were able to go in the clinic and not have to wait for long because they were linked automatically in touch with providers, and then they will be able to receive services in an easy and quick way. For the first question around the evidence to recommend self-care, I think here I also want to remind people that self-care it's not really new. Maybe because we are talking about self-care around SRH, it may seem new, But I think quality of care around safe care, this is something new. For the evidence, if you look at the safe care guidelines, the WHO safe care guidelines, there is mentioned references of various evidence that they use to come up with those guidelines. So I think it will be a good document to read and to read. Thank you.
Thank you, Dr. Dorine. So with this, if the audience, I'm sure this is a new area and we have lots of things in our mind and that we want to explore, as Dr. Irakunda said, we can get into the team and try to explore more and update ourselves and get involved. So with this, we will wind up the discussion on self-care. Thank you, Dr. Irakunda.
Thank you very much, Dr. Marcus, for moderating this interesting session, and Dr. Irakunda for giving us a very good insight towards this new approach towards reproductive health care during the pandemic. So the second state of art lecture will be provided by Professor Sarah. Professor Sarah Prager is a professor in the University of Washington, Department of Obstetrics and Gynecology, and adjunct professor of health services at the University of Washington School of Public Health. She's a director of Family Planning Division and a fellowship in Family Planning. She has over 45 publications in peer-reviewed journals and has co-authored 3 chapters and 2 up-to-date topics. Dr. Prager was part of the working group that updated the most recent CDC medical eligibility criteria for contraception use and selected practice recommendations, which are both published in 2016. She has done work with American College of Obstetrics and Gynecology since 2001, and she's a co-chair of the Abortion Access and Training Work Group. Since 2009, she has participated in global family planning projects in Nepal, Pakistan, Uganda, Zambia, and Zimbabwe, and spent the academic year in 2019-2020 during her sabbatical from the University of Washington and on faculty of the OBGYN department here in Addis Ababa at St. Paul Hospital, Millennium Medical College. Her specific focus in Ethiopia is supporting a growing family planning fellowship program. We are very much honored to have such a remarkable expert with us. So she will have 15-20 minutes of lecture followed by a live question and answer discussion.
Well, good afternoon, and it's really nice to be here with you all, even virtually. And my name is Sarah Prager. I'm going to be presenting today on provision of abortion and family planning services amid COVID-19. I'll be discussing some challenges and mitigations. I have no financial disclosures. My first objective for this conversation is to demonstrate the importance of maintaining safe abortion, post-abortion, and family planning services. I'm going to describe some ways to facilitate family planning provision and also present a no-touch or low-touch medication abortion option that people can consider. Well, the challenge, I think, is quite clear. Beginning on March 13th in 2020 was the first diagnosed coronavirus 19 case in Ethiopia. And immediately, both St. Paul Hospital and also ESOG and others around the country started planning for the impact that this would have on abortion and family planning services. A lot of non-essential services, medical services, were canceled at all of the hospitals and clinics, and people were encouraged to only seek care for urgent health needs. But abortion and family planning are urgent, and I think this was immediately recognized and mentioned by ESOG. And I think we can also see this. Guttmacher Institute published a study since coronavirus started, and they were looking at what would be the global impact of coronavirus 19 if there was only a 10% service reduction of sexual and reproductive health in low and middle income countries like Ethiopia. And they estimated or projected that this would lead to over 48 million additional women with an unmet need for family planning, which would also mean over 15 million additional unintended pregnancies. And additionally, this would be over 1.7 million major obstetric complications and 28,000 additional maternal deaths. Finally, this would also lead to over 3.3 million additional unsafe abortions and another 1,000 additional maternal deaths. So that is quite sobering. These are horrifically large numbers and really would indicate a really enormous negative impact with this relatively small reduction in global services of sexual and reproductive health. We were quite concerned about this also at St. Paul's Hospital, and so a number of us looked at these data, primarily my fellows listed here as the authors, to see what would be the effect of the COVID-19 pandemic on safe abortion and contraceptive services at our hospital. The methods we used were quite simple. We just compared the numbers of cases from March through May of 2019 versus March through May of 2020. And we were looking at safe abortion care, post-abortion care, and then interval postpartum and post-abortion family planning. I'm going to show you a few of our results. What the first thing we saw was a reduction in safe abortion care of approximately 16%, as well as a reduction in post-abortion care of almost 20%. Looking at this table in the upper left-hand corner, we see that the interval and post-abortion family planning uptake was reduced approximately 27% at the Michu Clinic, and then among our patients who had sought safe abortion or post-abortion care, there was approximately a 40% reduction in family planning uptake. And then if you look in the postpartum population, we did see that there was a reduction in the total number of deliveries from March through May of 2019 to March through May of 2020. That reduction was about 27%. However, the reduction in immediate postpartum family planning provided was over 66%, so not at all commensurate with the reduction in total numbers of deliveries. These numbers suggest that the impact of the pandemic on decreasing access to reproductive health, sexual and reproductive health, could be even greater than what Guttmacher was estimating. This also leads us to some of the ideas for mitigation of these particular challenges and potential harms. We know that at the beginning of the pandemic, a lot of patients were very reluctant to even come to the clinic, and this is still true, both in Ethiopia and in the United States. As well, many providers are wanting to discharge patients as soon as possible from the clinic or from the hospital and really limit the amount of time spent in care provision. However, looking at the data that we've already seen, what we know is that really we should be maximizing immediate postpartum and post-abortion family planning for a number of very good reasons, especially in the time of coronavirus. We know the patient is already there in the clinic. There's no barrier to them getting there. Secondly, there's a very limited additional need for other resources, including PE, and there's also limited additional coronavirus risk either to the providers or to the patients because, again, they're already there. That risk is already covered. I want to now spend a couple of minutes going over what some of the approaches were in the United States at the beginning of the pandemic. I need to preface this by saying that there was not a nationwide response to the pandemic in the United States, especially around issues of sexual and reproductive health. And that was done really on a state-by-state basis and sometimes even on a more local level. So some of what I will be presenting will be more specific to my setup at my university hospital in the United States. The protocol that was put together in Washington State, where I am now, I'm going to look at what that was for patients seeking family planning when they did not currently have any coronavirus symptoms. If they were wanting a prescription or a refill for their birth control or for emergency contraception, then we attempted to fill that clinic need just with a telemedicine visit. So we would either call them over the phone or use video conferencing like this so that we could speak to them and see them at the same time, and then simply send a prescription to a pharmacy so that they had no need to come into the clinic. Many patients were quite happy with this option, as they also did not want to come in and be in a clinic setting if they did not need to. Some patients, however, wanted to have a long-acting reversible contraceptive method like an IUD or an implant placed, or they wanted a Depo-Provera injection, or they needed their LARC device replaced. These instances, we would invite them to come in, as well as any patient who had an urgent concern, such as pain or heavy bleeding, or some concern about an ectopic pregnancy, and they would be seen in person. If patients were requesting to have a long-acting reversible contraceptive method removed, then the first thing that we would do is speak to them over the phone and discuss the evidence-based extended use regimens. For instance, the copper IUD in our country is approved for 10 years. However, we routinely use it for at least 12 years based on the evidence, and the levonorgestrel IUD, which can be is approved for 5 years, can be used for up to 7. If patients were accepting of having a more extended use for their LARC device, then we would allow them to not come in for any patient who still wanted to have an IUD or an implant removed was allowed to come in so that they could obtain that service. If patients were seeking permanent contraception, like a tubal ligation, then we would first ask them if there were other acceptable alternative methods of contraception. And if there were, then we asked them to defer that visit. At the beginning of the pandemic, when we had very limited resources, now that has been lifted quite a bit, and we are scheduling patients more regularly, even for tubal ligations. However, again, even at the beginning of the pandemic, if there was an urgent need for permanent contraception, then we made the best attempt we could to get that scheduled. Switching to safe abortion care and early pregnancy loss management for patients who did not have COVID symptoms, we again tried to maximize our telephone or telemedicine options initially. And a lot of the counseling was done over the telephone, and we tried to then limit the amount of time that a patient would need to spend actually in a clinical setting. If they came in for their abortion, either a medication abortion or an aspiration abortion, then after their telephone counseling, that was a much shorter visit. They could sign a consent form and then get their medication or have their procedure. If they were in the second trimester, then they were scheduled for a second visit, the first visit being taken up with their cervical preparation. Typically, we were having routine follow-up visits for our patients who had abortion care. And unless patients requested a follow-up visit, we no longer required this during the coronavirus pandemic situation. And then for early pregnancy loss management, that was treated exactly the same as patients coming in for abortion care. If there was any urgent need for them to be there, they could come in immediately. However, if they wanted to manage things with medication, then that could be just called into a pharmacy. The situation was a bit different, however, if patients actually did have symptoms of coronavirus. All of our patients were screened over the telephone before coming in. I know at St. Paul's Hospital, they set up screening setups at some of the entrance gates. And so it was very similar to that. If they had a fever or a cough or shortness of breath, they were sent for a more thorough coronavirus evaluation before they came in for their reproductive health visit. And eventually we also were able to do coronavirus tests for all. If they didn't have an urgent need to be seen in the next 7 days, and then we asked them if we could just reschedule that visit until a time that they were no longer infectious or symptomatic. However, every patient who met the following criteria, we did still see without delay. And those were patients who were over 22 weeks desiring abortion, those who had a fetal demise at greater than 15 weeks, any patient who already had cervical dilators in place and needed to have their abortion procedure continued, and then any urgent procedure that was indicated, for example, if they were having already heavy bleeding or any other serious complication. Well, I mentioned a little bit about medication abortion, but I'm going to talk a little bit more about that because I also think that this is, we all know that medication abortion is much more commonly abortion in Ethiopia and in many places around the world. In the pre-COVID time period, many protocols for medication abortion involved pre-treatment ultrasounds as well as in-person follow-up and other pre-treatment tests. In this post-coronavirus world, we are seeing more and more this concept of a no-test abortion where those treatments aren't required. I've already mentioned telemedicine, and the no-test abortion can certainly utilize telemedicine. This is technology that's been implemented in many places to decrease the need for face-to-face medical care. However, even if a particular site is unable to provide telemedicine, there are many lessons that can still be implemented from these protocols I'm about to describe. This concept of a no-test medication abortion means exactly that. There is no ultrasound or exam or blood tests that are then required prior to providing a medication abortion service. And we rely only on patient history or possibly a urine pregnancy test in terms of gestational dating. So before treatment, we would confirm the pregnancy just by taking a patient history, when was the last menstrual period, estimate the gestational age based on that, exclude the ectopic pregnancy based on history, and then also exclude other potential contraindications that might exist against medication abortion. At that point, the mifepristone and the misoprostol could be provided. And then after the treatment, instead of requiring an in-person follow-up, we would simply tell patients what they should anticipate if there was a complication. And if they had a process that seemed consistent with completing their medication abortion, they did not need to follow up. If they were concerned, they were told they could check a urine pregnancy test 4 weeks after the procedure. And if that was negative, it was a good indication that everything was normal. A lot of people expressed concern about not using the pre-treatment ultrasound and how are patients ever going to know how far along their pregnancy is. Well, going back as far as 2000, there are a lot of studies that have actually looked specifically at this issue. This top study in 2000 was looking at the accuracy of assessment of pregnancy duration by women seeking early abortions. And I'm not going to go through in detail all of these different studies, just to indicate that studies have been done in the United States, they have been done in Sweden, and then more studies have been done, including in Canada and Ireland, in South Africa. And even very recently, these studies looking at not needing lots of testing and screening prior to a medication abortion have all consistently found the same thing. Patients know how far along their pregnancies are, and even without other testing and screening, the medication abortion can generally be provided in a very safe and effective fashion. I should also say that organizations such as the WHO, as well as the National Abortion Federation, have included not needing an ultrasound into protocols for many years now. And the Ethiopian protocols also do not require an ultrasound prior to medication abortion. So we're actually ahead of the game in Ethiopia than we are in the United States. In contraception, earlier this year, this was a commentary published speaking specifically about the no-test medication abortion, and it included a sample protocol which was designed specifically to increase access to abortion during the current pandemic, but also beyond that. And I encourage all of you to look at this particular protocol if you have an interest in knowing exactly what that protocol entailed. However, we certainly found in the United States, and I'm sure we also see this in Ethiopia, that change is really hard. A lot of people don't want to adjust, even when we have to change very, very quickly because of a global pandemic. The protocols that I showed before hopefully can be used to make any changes necessary much, much easier to implement. And certainly you can know that these are happening around the globe, and these changes are being implemented so that access to contraception abortion is hopefully not altered too severely due to this global pandemic. My first take-home message is that medication abortion can be done very safely with minimal testing and surveillance. Secondly, I would really like us all to think about a harm reduction approach when we're making decisions about what protocols should be in place during a pandemic. We don't want to deny somebody access simply because it might be the very best possible thing to do to have one test or another test. If something can still be done very safely, including with an added measure of safety in the situation of a coronavirus pandemic, then that might be actually the better choice. And ultimately, access to abortion lives, and so we need to work very hard to make sure that they remain accessible even during a global pandemic. Thank you very much, and I'm happy to take any questions.
Thank you very much, Professor Sarah, for this timely and informative talk. Actually, most of the interventions that have been discussed almost entirely can be applied or adapted in similar setting like ours. So it was very nice having you to discuss those mitigation strategies. Now the floor is open for discussion. You can take questions from online and from the room. Maybe while we are waiting question from the audience, Professor Sarah, I have one question, probably a follow-up. So we are now 8-10 months through the pandemic. So how are these adaptive techniques working so far? How do you have any new study findings? How these new intervention adaptive techniques are really working in your setup?
Hi, Dr. Tesfaye. Thank you. Can you hear me?
Here we have one more question from the audience. Then I'll get back to you.
Great. Thank you for the question. I can tell you that the success of these strategies is really variable depending on the primarily legal, but also other approaches to sexual and reproductive health in a particular country, or sometimes, like in the United States, a particular state. We are seeing in the United States that medication abortion has increased significantly over the course of the pandemic, and that is also being seen to a certain extent in other countries around the globe. there is actually a shortage of the medication abortion medications of mifepristone and misoprostol in the United States for a period of time, although this also has been ameliorated more recently, so it didn't make a huge impact. And a lot of places have been able to continue to serve their patient populations by offering more medication abortion. In terms of contraception, we are seeing decreases in contraception usage in the United States, just like we did and do in Ethiopia. And so I suspect that there certainly is still an impact both on contraception use and access to abortion. But I do think that some of these strategies, particularly around increasing medication abortion, have been helpful at reducing the impact.
Thank you very much, Professor Sarah. We have one more question from the audience.
Thank you, Professor Sarah. My name is Magdas. I am your fellow. I wanted to add one more thing, which you have already started addressing, like the challenge in keeping some medications and some important materials when pandemics come. For example, you've said that there is now more shift to medication abortion, where there is now that there were like interruptions or even shortages in some places. Not just that, but also even for surgical, what about equipment and other things what are some of the mitigation strategies that we have to consider in supply chain management that you can propose? And taking the previous presentation also with self-care, and you have already addressed there was initially teleuse, telemedicine use, and what about how do you envision the next few years, be it with the pandemic or post the pandemic? How can we proceed and increasing accessibility and acceptability of self-care, and also use of the innovations that we have used to address this pandemic? Thank you.
Hi, Dr. Magdas. Thank you for your question. I'll address the second question first, which is that I think all of the mitigation strategies that have been mentioned, both around self-care and around making reproductive health more accessible, can and should be continued beyond a pandemic. These are all really common sense strategies that have been found to be very safe. They're not reducing the quality of the care, and there's no reason why we need to only implement some of these changes during a pandemic. I think particularly the telehealth, it can be extremely useful. A lot of people live rurally, and it can be challenging for them to get to a health facility and save hours and hours and money, and people miss jobs, and it's really impactful if they have to physically come to a clinic. And certainly there are things that we do that require somebody to be in person, but there are many, many things that we do that can be done over the telephone or through telehealth. And we are seeing in the United States that the regulatory bodies here are even adjusting to allow for telehealth to be an acceptable format for providing care. And we are hopeful here, and I'm hoping around the globe, that this will continue to be more of a trend, because lots of people don't want to go to a hospital or go to a clinic, even when there's not a global pandemic. And they shouldn't be required to travel hours and hours if a physical exam or some other type of test is not actually required. Of course, there are lots of things that will still require patients to be seen in person, but not everything. As far as supply chain, I really think the strategies around flattening the curve of the coronavirus are helpful also for those supply chain issues. The problem isn't so much the total volume of patients, it's how that volume presents for care. And if we can make contraception accessible on a continued basis, then we're going to see that our abortion supplies are going to be more readily available when patients need them. So looking again at all of the upstream factors that lead to patients needing to get an abortion or can decrease the chances that a patient would need to get an abortion, it's really critical to maintain access to all of those things so that the supply chain around abortion doesn't all of the sudden become short because we've not been providing all of those other things, and now you have an increase in the number of patients who are requiring abortion. And then again, you know, flattening the curve around coronavirus will also just leave more healthcare professionals and systems open and available so that all of these services, including sexual and reproductive health, can remain available.
Thank you very much, Professor. For the sake of time, we will take one last question from it.
Good morning, Professor Sarah. This is Balkacho. Part of the reason that I wanted to take the mic is to say thank you very much for joining us at this very early time of the day in your time zone. We really appreciate that. But I would be very happy if you touch on the infrastructure related changes that you make at the family planning and CAC service areas. Thank you.
Thank you, Dr. Balkacho. It's so nice to hear your voice and everybody's voice, and I'm so happy to be here. I appreciate the invitation. I think from an infrastructure standpoint, the focus actually needs to be largely on just maintaining availability. And what I mentioned at the very beginning, that a lot of healthcare services that were considered non-essential were shut down. This is not something that can apply to sexual and reproductive health. I think we need to consider sexual and reproductive health always to be something that is relatively urgent. And from an infrastructure standpoint, just keeping access open is really the change as compared to other types of care that may not be as necessary. And certainly some things, you know, some other types of care can be spaced out and not require patients to come with the same frequency. But again, thinking about making sure that those clinics remain open and that, as I mentioned before, you know, not requiring an ultrasound necessarily before giving somebody mifepristone and misoprostol, or not requiring an RH test in the first trimester because the opportunity for fetal red blood cells to be in the maternal circulation is so low and likely not to cause an isoimmunization response. Or even sometimes not requiring a blood pressure for a patient who is seeking a contraception that has estrogen in it, as long as that person doesn't have any history of high blood pressure. So these sorts of infrastructure changes are the ones that I think we can think about with respect to maintaining these services during a pandemic.
Okay, thank you very much, Professor Sarah. I think that's all we have. Again, to thank you very much on behalf of the organizing committee. We know that you are going to have a long day. It's early in the morning, so we wish you a very nice and beautiful day. Thank you very much again, and I will also want to thank the participants for your active participation. Thank you very much.
Thank you. Have a great evening.
I think this will bring us to the last session of the symposium. So as per our schedule, the final session will be the award session. So I will call upon the award committee chair to come to the stage.
Okay, thank you, Dr. Tasfai. Good afternoon, everybody. And good morning, those of you who are online. So I would like to just thank everybody in the name of the awarding committee. So for the past 2 days, there were, as you know, there were different papers which were presented. So every paper was competitive, as already selected from the initial submission. So we try to evaluate all papers that were presented, except the one which was not presented. So based on the 15 criteria which were already designed to select the best paper, although all the papers were best, but we have to choose one of the paper from it. So based on this, the paper that was win the award is with the title of The Panic Phase of the Epidemic, the Impact of the Early Phase of the COVID-19 on Reproductive, Maternal, Newborn, and the Child Health Service Utilization at the Tertiary Hospital and the Catchment Health Centers. So that was presented by Dr. Delayo. So this is the award-winning presentation. I would like to announce this. Thank you very much.
Thank you, Dr. Tadessa. Before you go, we have the present, even if we don't have the winner. So I ask Dr. Tadessa to open the award and show for the audience and for the online participants. Thank you.
So this is the award.
Okay, I think this will bring us to the end of the 2-day National Reproductive Health Symposium. We had a very fruitful 2 days. I want to thank the organizing committee, the participants, the Ministry of Health people, and all the panelists. Thank you very much. I hope you all the best for the rest of the year. Thank you. So before we end the session, I think there are very important people that we need to recognize. I will call upon Dr. Balkacho to recognize those people.
Thank you very much, everyone, those who are online and those in the room. So our institution, St. Paul's Institute for Reproductive Health and Rights, have gone through different processes to reach to this level, and we would like to recognize the organizing committee, the whole of them, and there is the scientific committee led by Dr. Tasfai Horisa, the whole team here, the award selection team. We know we all are under significant emotional distress because of the situation in the north, but despite all that, you have been here for the whole 2 sessions. Those who are online in here, and we are really grateful for that. We couldn't push this to another time, but we had to conduct it at this stressful time. But despite that, you all were here with us during this session, and we are really thankful. So I would like to just mention names that were that have significant contribution to the success of this year's symposium. Dr. Matthias Asrat, he was the scientific committee member. Dr. Farid Abbas, another scientific committee member. Dr. Delayo Bekele, another scientific committee member, and Dr. Tesfaye Horesa, who is the chair of the scientific committee member, and our two state-of-the-art instructors, Professor Sarah Prejer and Dr. Dorine. Dr. Merkite Wandafra, she is the organizing committee and also part of the scientific committee. Dr. Magda Staba, who is the scientific committee member. Dr. Wondimu Gudu, presenter. Dr. Zabanay Workana, Dr. Dagana Baharai, Dr. Negalign Mechal, and Dr. Wondimu Gudu, who are presenters in this session, including Dr. Delayo, who was the winner of best oral presentation, Dr. Tashagar Mersha, and Dr. Jemaw Assefa, both were presenters in this session. And Dr. Abraham Getachew, Dr. Taddesa Urge, and Dr. Abraham Fasahaye were the selection committee members for the best oral presentation. I thank you all and thank you. See you next year.
Thank you.